to try to teach you what's relevant. I wanna ask you guys to introduce yourself. Just tell me where you're from and what level of training you have, and then we can go ahead and start doing some open discussion. So we can start with you again.
Hi guys, I'm Katie.
Katie. I'm gonna try to remember the names. I'm not very good at it, but.
Cincinnati. Go to school at Butler University in Indianapolis, and I'm a PA student, so this is my clinical year.
Second year, right?
Yeah,
Second year. Very good. So you're graduating next summer.
Yes.
Very good. Perfect. What field are you interested in going into?
I don't know yet.
You don't know yet.
No.
Okay. Very good. How about yourself?
Hi, I'm Allison. So I kind of have like the same background as you. I'm an international student as well.
Oh, wonderful.
But I'm going to medical school here in Philadelphia. And I'm a third year medical student.
Very good.
And I'm interested in obstetrics and gynecology.
Wonderful. Excellent. And is that a DO program?
Yes,
your
yeah,
program?
yeah.
Perfect. Okay. How about yourself?
My name's Beth. I'm from Indiana and I go to school at Butler, so I'm in K-year classes.
Wonderful.
And what else was it?
In what field are you
What
interested
field? Right now I like surgery.
in? General surgery. Wonderful.
Yeah, just general, maybe, but just any kind of surgery.
He can take you to his cases. He used to take me to his
I
cases.
have gone to the
Wonderful.
hospital with him in the cath lab before, so.
Wonderful. Okay. How about yourself?
Oh, I'm Maywish. I go to school in Kansas City at the DO program there. I'm a fourth year medical student, and I'll be applying for family medicine next month, actually.
Wonderful. Wonderful. So the match starts now. The match is in March, right?
We'll find out where we match.
Match in March. So but your applications are in, and you're going to be interviewing all over the country. And,
Next month we submit applications.
Wonderful.
For ACG.
Okay. What about yourself?
My name's Luda. I'm from Washington, and I went to going to school at Pacific Northwest DO program.
Mm-hmm.
And I'm a fourth year student, and I want to go into internal medicine.
Internal medicine. Wonderful. Yeah. How about yourself, Mike?
So I'm at the same school as Luda. I'm thinking radiology.
Radiology. Very good.
Yeah.
Yeah. So, yeah, whether you're going to family surgery, OBGYN, this knowledge is highly tested. It's actually the backbone of the boards. And have you guys taken a step 3, or you guys are in the process, or? Okay. So yeah, we'll make it very, very, very useful. So, just a little disclosure: if I get paged, I need to return a call because I'm on call for the hospital that I cover, but that happens infrequently. Very good. So. Why don't we start with, I'm going to use this as a reference to actually try to condensate the higher yield type of questions that you're going to be getting on your boards. So just pull it up really quick. I had a very interesting case today that I want to share with you guys because it's highly tested on your boards as well. OPQR nephrology. Okay. Very good. So, very good. So, for nephrology, nephrology is fun. It's not as hard as you think it is. It's one of those fields that I thought it was very abstract, but a lot of the things make sense. And I'm going to try to make you think as a nephrologist during the next hour. I'm going to talk about 1 hour about nephrology and 1 hour about rheumatology. What I always tell students and residents is that you never go to a cardiologist without an EKG. And I get students and residents coming to me presenting a case without a UA. And it's funny, but we forget that, and that's where the money is in nephrology. It tells you a lot of things about what goes on in the kidney, if there's any inflammation, if there's any casts, if there's any protein in the urine, and that way you can make your differential diagnosis and you can divide up things depending on the urinalysis findings. Important things to know for the boards. They love to ask a question about the mismatch between protein in the urine on a dipstick and protein in the urine when you quantify it either by spot urine for protein creatinine or by a 24-hour urine collection. Why is it important? Because remember, when you do a dipstick, you're only measuring albumin, but the human kidney can pee non-albumin proteins. And that's the key. So you may be presented with a question on an elderly person or somebody in their 50s or 60s complaining of bone pain, and you look at the labs and there's a little bit of renal insufficiency, there's a little bit of anemia, and they wanna trick you. But the key thing on that question, you can come in. The key thing on that question to always remember is that the dipstick does not assess for non-albumin proteins. And the reason is that they don't do the sulfoxylic acid assay. Therefore, you can very easily miss paraproteins. Remember multiple myeloma or Benz-Jones proteinuria? So always think about it. If they show you a dipstick with no proteinuria, and then you look at the 24-hour and the patient has 2,000 or 3,000 milligram, whatever it is, that person has multiple myeloma until proven otherwise. So multiple myeloma is a board favorite because multiple myeloma is quite toxic to the kidneys. It is estimated that there's at least 6 different mechanistic ways of myeloma injuring the kidney. I'm going to mention some of them so you're familiar with how aggressive this disease can be in the kidney. If you remember, the main thing on multiple myeloma is that there is a monoclonal proliferation of one of the B cell lines, and the monoclonal proliferation actually floods the kidney with this very insoluble protein called Benz-Jones. We call them Benz-Jones proteins, and that in itself is very toxic to the kidneys because when it tries to filter through the tubules, it causes a lot of stasis or urinary stasis, and that can actually ultimately result into acute tubular necrosis associated with the urinary stasis. So if they tell you, if you ever read or if you encounter the term myeloma kidney, that's what it means, that it's a lot of Benz-Jones proteins actually clogging up those tubules and causing ATN. But multiple myeloma can also injure the kidneys in different ways. There is light chain deposition causing a lot of inflammation. There's heavy chain deposition causing a lot of inflammation. Patients get a lot of interstitial nephritis. I don't know if have you heard about acute interstitial nephritis? So multiple myeloma is one of the differential for acute interstitial nephritis. You probably remember that in the boards they always concentrate on beta-lactam antibiotics or proton pump inhibitors, but also multiple myeloma. When you see interstitial nephritis, probably the 2 more common that they test that are not medication related are multiple myeloma or sarcoidosis, which can happen also in the kidneys. Sarcoidosis can happen anywhere, but I've seen sarcoidosis, crazy cases of sarcoidosis, like even in the ear. It can happen anywhere, but as long as you remember that one of the manifestations in the kidney is acute tubular interstitial nephritis. So, and there is also another way that multiple myeloma injures the kidneys by causing hypercalcemia. Hypercalcemia, as you guys know, it causes it causes a lot of pre-renal azotemia. The patients start like having polyuria. They start urinating a lot, and when the calcium is pretty high, there is actually direct deposition in the kidneys and damage. So you can tell that there is a lot going on. But for your level of training, probably pay a lot of attention on this mismatch of no protein detected in the dipstick and a lot of protein detected in the quantification. So always remember that. Okay, so very good. So when you get a case of urine, the most important things that you need to know is that blood can come from anywhere in the urinary tract, including the kidneys. If they show you or if they tell you that the patient has either dysmorphic RBCs, that's the key word, dysmorphic, or they're getting more sophisticated, they may tell you acanthocytes. Acanthocytes is like the Mickey Mouse looking red blood cells. They're cells that have been deformed by the passage through the glomeruli, and they look funny on the microscopy of the urine. So when you hear either acanthocytes or you hear dysmorphic RBCs, you know for a fact that you're dealing with glomerular hematuria. That blood is coming from the kidneys. That's never normal. That almost, as a kidney doctor, when I see that, it's like if Dr. Ben-Zur starts seeing like ST depression in the anterior leads. He needs to take that patient to the cath lab. That person needs like to get a cath. Period. For me, when I see that in my profession, that means that I need a kidney biopsy if the patient can get a kidney biopsy, because not every patient can, for whatever reason. Like we can go over indications for renal biopsy later, but so acanthocytes or dysmorphic RBCs equals glomerular hematuria, almost always equal primary intrinsic disease of the kidney. And we'll talk about it in a minute because the differential is quite large, but I want to warn you that on your boards, that's one of the things they do. Another very commonly tested concept on the boards is the muddy brown cast. You guys remember the muddy brown cast? You guys know what that means? Acute tubular necrosis. So I love to discuss ATN with students because my job is to make them understand that ATN is a syndrome. ATN is not a diagnosis. It's like when you come to me and you tell me, oh, the patient has a fever. I'm going to tell you, fever from what? Fever can be from an infection or non-infectious or malignancy or so on and so forth. Same thing in ATN. ATN, I can give you right now like 10 different conditions that causes ATN in the kidney. Can you guys give me at least one or two? Medications, yeah, so some medications can deposit and they can cause damage to the kidneys. I'm going to give you some examples. For instance, as acyclovir. When you prescribe acyclovir in the urgent care, you tell the patient drink a lot of fluid because acyclovir can actually cause a condition called crystal-induced acute kidney injury, and those crystals can be actually toxic to the kidney and can cause ATN. That's good. So medications. What else? What other things do you guys remember? Who can develop ischemia from what?
From like significant, like pre-renal.
Exactly, from anything. Like if you get a patient like vomiting massively. I just got a cancer patient last night. The guy newly diagnosed cancer. He wasn't eating. He came in profound ATN. So that's for any reason, hypovolemic shock, or you get a distributed shock. You know, there's different types of shocks. You know, we have the hypovolemic. We have the septic shock. We also call it distributed shock. The kidneys are extremely sensitive organs. Part of the reason is that the body wants to make sure that we are supplying the brain and the heart, the two more important vital organs. And the kidneys, very commonly, I get involved in pretty much in every patient in the hospital that's not doing well. They call me because the kidneys are one of the first manifestations that there's something wrong and there's something going wrong. So ischemia is probably one of the top causes, but you can also get ATN from hemodynamic insults. For instance, if a patient gets medication-induced hypotension, even patients that, let's say that they were running in the 180s and you do a very aggressive blood pressure control and the blood pressure normalizes to 110, even something like that, something as simple as that, I very commonly get involved in patients like that in the hospital. They come with very high blood pressure and the doctors, they get very excited, like adding new medications, and the next thing you know, like they tank and the kidneys take a hit. So any type of decreased perfusion or any type of ischemic or dehydration insult can result into ATN. What else? Other examples of ATN, guys. You need to remember that. For instance, there's a very common entity that you're going to see throughout your careers. Even if you go into surgery or gynecology, you're going to be dealing with this real entity, which is called contrast-induced nephropathy. Have you guys heard about that? Mm-hmm. So contrast-induced nephropathy is common. Fortunately, most patients actually they get better. You know, the three possible outcomes when you go into profound ATN, there's three outcomes. You either recover fully, you are left with residual renal damage, meaning that you went to a new level of renal function, or you never recover. And fortunately, for patients without pre-existing kidney disease, it's more common to see a total recovery than a partial recovery than no recovery at all. But that's not the case for the elderly or patients with other comorbidities. For instance, the patients that Dr. Ben-Zur takes care of, they're very sick. They're patients that most of them have elements of cardiorenal syndrome. Have you guys heard about cardiorenal syndrome? So cardiorenal syndrome is a myriad of manifestations, but the ultimate pathway is that there is decreased effective circulatory volume to those kidneys, and those patients have compromised renal function because the heart, the liver, and the kidneys, they're very interconnected. Have you guys heard about hepatorenal syndrome? We'll talk about hepatorenal syndrome in a minute, but it's another way of explaining physiopathology, how sensitive the kidneys are, and the ultimate pathway for all of those examples that I just used is ATN. So remember, ATN is a syndrome, it's not a diagnosis. So when you come to me like, oh, ATN because I saw muddy brown cast, like ATN from what? And it's important that you understand what causes it, because that's how you're going to treat the patient. Another example that you guys in surgery are going to be seeing, rhabdo. Rhabdo, like from a crushing injury or from malpositioning of the patient. I had a case the other day when I was at one of the hospitals at UCLA. This guy who's very large person, he started supposed whatever surgery, and apparently his leg got caught. So that's why the nurses are very anal about these protocols of rotating the patients or make sure they move them properly. So this person was found with his leg caught like for an hour. That was enough for this person to go into really bad rhabdo, like really bad renal failure. And then, like every time I get involved in a post-operative case of renal failure, just a good tip for you guys, just send a CPK, because you can go into rhabdo from the trauma itself, the trauma of surgery itself, from malpositioning or for not rotating the patients efficiently, or some anesthesia drugs can actually cause idiosyncratic reactions, and you can actually go into rhabdomyolysis, and these patients, they get very, very sick. And you need to recognize that what the cause of the ATN is from rhabdo, so you can provide the patients with the right treatment. For instance, for rhabdo, the treatment is you need to flood them with fluids. If they're urinating, if they're not urinating, there's nothing you can do. Probably you're going to have to dialyze that patient. But that's an example of how important it is to recognize what the cause is, so you can actually revert the cause. Okay, so ATN, very heavily tested on the boards. In medical school, they spend a lot of time teaching you guys about the FINA and about the, what's the name of that, the FE urea. And you're gonna laugh if I tell you that most nephrologists, they don't even know how to calculate it, and we don't necessarily use that because it's not helpful. There's a lot of instances where FINA can be misleading, and in my field, like as a student, I tell my students, like, whenever you go and interview a patient, you're going to have the answer of you're going to have your renal diagnosis like 90% of the times. For the other 10% of the times, if you can't figure it out, I'm probably not going to be able to figure it out like up front, and those patients are going to need probably a biopsy to be able to recognize. So when you're confronted with a patient with ATN, what's the treatment for ATN, guys, by the way? Really quick. Treat the underlying. There's no magic bullet. There's only time. I have a patient right now. She's day 4 that she's not making any urine, and everybody's very anxious, asking me like, when do you give her dialysis? So it's a clinical decision, and it's a daily assessment type of thing. But there's no treatment for ATN. There is just wait, remove the offending cause, and most patients do recover. For those that don't recover, we need to dialyze, and that's a clinical decision that the nephrologist makes. Okay, so very good. So urinalysis, probably those are the most important things. If you see WBC casts in the UA, what do you think about? Which one?
Pyelonephritis.
You see pyelonephritis, and what else? If they tell you, we talk about acute interstitial nephritis. So in acute interstitial nephritis, you can see WBC cast, or you can see urine eosinophils. Fortunately, the #1 cause of kidney injury is ATN. The second cause is ATN. The third cause is ATN. The fourth cause is ATN. And only about 5% of the acute kidney injury is related to acute interstitial nephritis. The key thing to understand is that a heavily tested disease on your boards, because it's so important that early recognition is so important, that because it makes the whole world of a difference. If I identify that this is a beta-lactam allergy, or this is a PPI-induced renal disease, if you don't stop it promptly, these patients may go into irreversible renal failure. That's the reason why I think it's so heavily tested. But I want to warn you that there are many other things that can give you urine eosinophils, and not necessarily it's a sensitive test, but it's not specific. And people with prostatitis or even acute glomerulonephritis or other things can give you urine eos, and that doesn't necessarily mean that you have AIN. The nice thing about the boards is they're very straightforward. They give you a urine eos, they're probably going to be asking you about AIN. But remember, the most common cause is drug-induced, and the 2 biggest offenders, beta-lactam antibiotics and PPIs. And there are other systemic conditions, even infections, that are associated with AIN. Okay, so another thing that's important to understand in the UA, so we talk about RBC cause, we talk about WBCs. Yeah, it's pretty much protein. We can talk about it when we cover nephrotic syndromes. But yeah, okay, very good. So hyponatremia, is that painful, guys? Painful enough? Okay, so hyponatremia fortunately is not heavily tested. I'm gonna give you like a 2-minute summary from a nephrologist how to approach it. So most of the hyponatremia cases on your boards are gonna be SIDH. SIDH, by definition, you have to have normal kidney function and you have to have a patient that's euvolemic. So the easy way to remember hypovolemia is that you divide it up in 3, either you're hypervolemic or you're hypovolemic or you're euvolemic. And most of the board questions are going to fall into this euvolemic category. For those that are hypervolemic, most of the time is heart failure. Most of the time, and you see this whenever you rotate in a cardiac care unit, if the patient is in really bad heart failure, when you diurese them, the sodium starts getting better on its own. But on your boards, again, the boards are very fair. They're not like real life, they're very fair. And they actually, hypervolemia and hyponatremia, most of the time is cardiogenic. So that's easy to get out of the way. So then we have the hypovolemic. They usually give you a history consistent with hypovolemia. Somebody that's whatever, vomiting or whatever the case is, and then that way you know that you need to go through this path. For those that fall into this category, there's only a couple of conditions that you need to rule out. 3 conditions. Either you have SIDH, I'm going to teach you how to diagnose SIDH, or you have adrenal insufficiency, or you have severe thyroid disease, like severe hypothyroidism. So when you get a patient, common things being common, remember, hoofs, you think about horses, not zebras. Common things being common, SIDH is by far the most common cause. But as a nephrologist, when I get called, I always try to rule out either adrenal insufficiency or severe thyroid disease. Most patients, somehow they've had a TSA checked in the last few months. If it's normal, you don't need to go further. For adrenal insufficiency, it gets a little more tricky. Adrenal insufficiency on your boards, they may present a patient with a constellation of symptoms. Adrenal insufficiency is actually, it happens more often than we clinicians diagnose it in clinical practice, because some patients can actually present with subclinical adrenal insufficiency, and they only become very obvious when they get in trouble, when their body's under stress because they develop an infectious insult or a bleeding insult, whatever it is, they become very obvious. But the key things to remember for your boards is that they may give you an individual that's dehydrated, that's actually failing to thrive. Just remember that word, failing to thrive. It's a person who is like having chronic diarrhea, decreased appetite, nausea, vomiting, accelerated weight loss, all of those failure to thrive type of features. Always think about adrenal insufficiency. Adrenal insufficiency can either be central or it can be actually Addison's disease, which is actually an autoimmune or unclear reason why there's destruction of the adrenal glands. But the patient with adrenal insufficiency and hyponatremia that actually has Addison's disease, one of the key things to understand is they present with hyperkalemia. They give you a low sodium and a high potassium. So if you see a low sodium and a high potassium on your boards, go that path. It's easy to remember. They're not going to tell you on your boards, they're not going to make you think like this person has central versus Addison's disease. Just high potassium, low sodium is adrenal insufficiency. And the SIDH patient, which is the vast majority of the questions on your boards, or the vast majority of patients in real life, those are patients that have an excess of antidiuretic hormone. Remember, our bodies have very tightly regulated osmolarity. Do you guys remember the osmolarity of the human body is? You guys remember? 290, 295. When you're actually going to 295, you're ready to kill for water. And because our bodies have very tightly regulated thirst center, pathways. So what happens is that the patients with SIDH, they inappropriately respond to non-osmotic stimulus. All of the people here in this room, it is very hot, we're sweating, osmolarity goes up, ADH release goes up, and then we drink and osmolarity goes down. What happens with SIDH is that for whatever reason, I'm going to include some of the examples, is patients with intractable nausea, patients with paraneoplastic syndromes. It's probably one of the things that you're more commonly seeing in clinical practice. Patients with, let's say, squamous cell carcinoma of the lung, or like lung malignancies, for whatever reason, they tend to secrete a lot of like ADH. Even space occupying lesions that are not necessarily paraneoplastic. Like for instance, I get involved in cases with like a bad pneumonia, like a lobar pneumonia. Those patients, they have excess of ADH circulating. And what happens is that as a student, I always had trouble in understanding, like, what do you mean by hyponatremia? Is it because I don't have enough sodium, or it's because I have a lot of water? And the way you need to explain to your patients, because the treatment of SIDH is fluid restriction. That's the treatment. I know there's a lot of drugs or a lot of like different things that they created, but I'm going to tell you that SIDH, if there is something that you're going to memorize from this talk today, SIDH is a water excess problem. It's not a salt deficiency problem. And you need to stick that concept in your patient's mind, because every time you tell them that your sodium is low, the next thing they go and start eating more salt. And that's actually detrimental if you're dealing with a nephrotic syndrome or a liver patient or a cardiac patient. You don't want to tell them eat more salt. It's a fundamental problem that is a water excess problem. So the ADH goes to the collecting tubule, and basically what it does is like it reabsorbs the water. It's an anti-diuretic hormone. So these patients you cannot tell that they're volume overloaded because they don't appear volume overloaded on exam. You look at them, they have no pedal edema, they have no crackles, yet they have intravascular water retention, and that's why the sodium drops. And hyponatremia can be safely managed as an outpatient, assuming that the sodium is there's a couple of things that you need to know. You need to understand the duration of the hyponatremia. How long has this been happening? If it happens, let's say on your boards, very commonly they ask you, the marathon runner, that instead of repleting the losses with whatever, Gatorade, whatever, they drink a lot of water. Like an experienced runner, they know that they shouldn't just be drinking plain water because it's dangerous. They do electrolyte drinks. So they may give you a patient that is a marathon runner that showed up in the ER with a seizure. The treatment for those patients is very straightforward. You need to give them 100 cc's of hypertonic saline until they stop seizing, and you can correct the sodium quickly without any risk for permanent neurological damage. Only for those patients. But the real life, most of the times we don't know how long have they been hyponatremic for. So whenever I don't know the duration, I need to understand that patient should be considered as a chronic, because I don't know. And the risk of correcting sodium very rapidly, you guys remember what the name of that condition is? They used to call it like that. Now they call it ODS, Osmotic Demyelination Syndrome. And the problem is that there's two problems with low sodium. When it goes down too quickly, what happens is that the brain cells, the neurons, they start like swallowing water just to try to equilibrate, and people seize. That's the first risk. You can develop, like, in your boards, they may give you a person using ecstasy, which it's pretty common. It's a pretty powerful ADH inducing agent. And what happens is that the kids give advice to the other kids, like, oh, you're going to be partying hard, so you need to drink a lot of water. And then that's actually the most horrible combination. You're taking an amphetamine and you're drinking water, and next thing is that your sodium is going to be 110. Like, sadly, where the hospital where I used to work before, like a young girl died exactly from what I'm describing, like permanent brain damage. So that's the acute hyponatremic induced damage. But there is another entity, very distinct entity, called osmotic demyelination that comes from overcorrection of the sodium, because when you overcorrect the sodium too quickly, there is not enough time in the brain to adjust for those changes in the intrinsic osmolarity of the brain, and people can actually start having like areas of demyelination and brain damage. And the key thing to understand about this condition is that the damage can happen up to 30 days after you corrected the sodium very quickly. In my field, there are few common cases of malpractice. In your chosen field, who's the OB? in your chosen field, there's many different ways of getting sued. Even when the kid is 18 years old, they can still sue you. I don't mean to discourage you from going in that field, but I'm just sharing with you guys, in my experience, the lawsuits that I've seen as a nephrologist from other nephrologists, they've come from overcorrection. And it's important that you guys understand that the correction rate should not exceed more than 8 milliequivalents in a 24-hour period. And a lot of the times, sounds silly, but a lot of the times I get involved when the damage is already done, and they call me for medical legal reasons, and I have to try to back correct the sodium. We call that therapeutic induction of hyponatremia. In other words, I'm trying to induce hyponatremia by giving the patients ADH and free water, so the patient doesn't develop the brain damage. So this is probably one of the few areas in my field that generates a lot of anxiety. Most nephrologists, they feel very fearful about outcomes, neurological outcomes. In the hospital where I used to work, like 10 years ago, 10 years prior, one of the attendants got sued because the patient developed locked-in syndrome associated with osmotic demyelination. So it's a pretty, you know, on your boards, they're gonna wanna know that you know how to diagnose SIDH. So euvolemia, urine osmolarity greater than, urine sodium greater than 40 and urine osmolarity greater than 100. The higher the urine osmolarity, the more likely you're dealing with SIDH. And on your boards, they also want to know that you understand there are non-osmotic stimulus for ADH release, including pain, nausea, medications, like probably the most common medications that can induce SIDH is SSRIs, or some of the psychotropic medications are like strongly associated with development of SIDH. Some of the recreational drugs like amphetamines and NSAIDs, even NSAIDs can actually induce SIDH. So once you have that clear, then you need to understand that the treatment is fluid restriction. Most doctors actually they prescribe different medications that are approved for the treatment of this condition. In my opinion, they're useless because the key thing to understand is that if you drink a lot, you're going to end up dropping your sodium. So the patient, once you understand that and you make the patient understand, you're going to cure 99% of the cases. In the hospital, we have a relatively new group of medicine called the aquaretics. They're actually direct inhibitors of the ADH in the collecting tubules. They're called the Vaptems. That's the name of the medication. What happens is that those medications are for inpatient use only, and they're very expensive. And like about 3 years ago, the FDA ended up showing a report on cases of fulminant liver failure associated with chronic use of these medicines. So it's a quick fix. Sometimes we need to do it. Let's say the patient needs to be ready for a cardiac procedure. We fix them, and then we continue with fluid restriction. But the management is fluid restriction.
So you can use the Vaptans in euvolemia?
Yeah. They're FDA approved for SIDH. And remember, by definition, SIDH is euvolemic. Okay?
So when you say you give it to them to get them ready for surgery,
right,
it will bring up their salt rather quickly, or
it will bring you the same rule of 8 milliequivalents in 24-hour applies.
Yeah.
But it's easier to achieve that goal because sometimes when the patients have very concentrated urine, bringing them up it's a little challenging just with fluid restriction. But the way I do it, because I already have experience and I'm less fearful because I know what I need to do if I overdo it, what I do is I give them little boluses of 3% saline. I don't recommend you do that because you don't have a way of defending that. But the key thing when let's say you're an intern on the case, you fluid restrict them. If you use the Vaptems, you need to be a little more cautious because the overcorrection can happen. And SIDH is completely unpredictable because the half-life of ADH in the human body is very short. It's like 2 to 4 hours. So what happens is that when you remove the stimulus, let's say that somebody was in a lot of pain or somebody had a lot of nausea, and somebody was taking Prozac, and I took off the Prozac, I controlled the nausea and I took away the pain. So there's no more non-osmotic stimulus. So the ADH wears off, and these patients, they start peeing like you wouldn't believe. It's scary to see that because you look at the urine and the urine looks like pure water, and that's what it is. It's very diluted. You measure the urine osmolality, and the urine is like always less than 100. It's very, very diluted urine, and those patients are the one that's not gonna. Those patients are gonna take away the sleep when you're in the middle of the night, and you have to be very careful about checking them. And if they're peeing a lot, like the management is, give them a little bit of DDAVP.
Okay.
You give them a little bit of DABP, and that works like $1 million. You know, it's like you go from a urine output of 600 cc's an hour to no urine output. That medication is pretty effective and pretty powerful. That's one of the uses in inpatient medicine. And another use that's commonly used by cardiothoracic surgeons, they use it because it stimulates the production of von Willebrand factor by the endothelium, and cardiothoracic surgeons, they use it for uremic bleeding prophylaxis. They use it like commonly when they fix a valve or they do something and the patients have advanced kidney disease. They tend to believe that helps prevent bleeding, like uremic bleed. But yeah, hyponatremia is tricky. You need to have it's real life cases, and you're gonna have enough during your training. But the key things for your boards: overcorrection is very dangerous. Acute drop in the sodium is very dangerous. So you need to give them hypertonic saline boluses. Okay. So hyperkalemia. Oh my gosh. So I'm going to read the key things, and I'm going to go from there. So don't be tricked. Absolute levels of potassium cannot be reliably determined if a life-threatening condition exists. Only EKG can assess the effect of hyperkalemia on the cardiac membrane. That's very true. A lot of the times they call me about hyperkalemia, and it's important to know that there's a condition called pseudo hyperkalemia. Do you guys know what can cause pseudo hyperkalemia? So if you have an inexperienced phlebotomist, hemolysis, and I see this all the time. If the patient is obese, their heart sticks, they're digging, they're causing a lot of trauma, they're like applying a lot of pressure. That's very common. How do you rule that out? You send the patient back and you tell them, don't let them use a tourniquet. If you do that, it will save you many headaches, and it will save you $1 million workup. And you ask the patient, did they suffer to find the vein? Oh yeah, all of them remember, oh yeah, I don't want to go back. But you tell them, just tell them to use like a butterfly, and they should do like one of your hand. And that's easy to rule out, pretty straightforward, and physician is happy, the patient is happy. So that's number one. But also you see pseudo hyperkalemia in some hematologic malignancies. Like if you see, let's say, patients with essential thrombocytosis, or patients with CLL, and they have like pretty prominent leukocytosis, that in itself can cause pseudo hyperkalemia. The key thing about pseudo hyperkalemia is that you don't treat it. You learn that it's there and you ignore it. And most of the time these patients have in the high 5s, probably in the low 6. It's never associated with EKG changes, and is never life-threatening. So if they ask you a question on your boards, look at the white blood cell count, look at the platelets, or the example that I use about the trauma. So that's pseudo hyperkalemia. For real hyperkalemia, it's definitely a clinical important consideration, and that's the reason why you guys are always obligated to do labs if you're going to prescribe an ACE inhibitor before and after. If you're going to prescribe an aldosterone blocker like spironolactone, you need to do labs before and after. Why? Because you can run into life-threatening hyperkalemia, especially now that people are running into more trendy foods. Have you guys heard about coconut water? People think that coconut water is the most healthy food that you can actually have. So coconut water is an overdose of potassium. If you want to kill a dialysis patient, just tell them to go drink a liter of coconut water. They're not going to make it through a night. So and this is a real clinical problem. So what I do in my practice, and I want to share this with you guys, if somebody has advanced or intermediate, probably stage 3 to 4 kidney disease, I always offer them education about low potassium. Do you guys remember what are the foods high in potassium?
Strawberry.
Which one?
Strawberry.
Yeah, but there are some others that are bananas. What else? Kiwi. What else? Quick.
Potatoes.
Avocados, right? Potatoes, tomatoes, coconut water, seaweed has a lot of potassium. Fortunately, nuts, most of the nuts have a lot of potassium and also phosphorus. And so I offer education Either I do it or I send them to a dietitian nutritional consult, because I believe in the power of ACE inhibitors and ARBs, and I want you guys to believe, if you're going into family and internal medicine, you have to have a very absolute compelling reason not to challenge someone. And if you don't educate them about low potassium, you're doing a disservice to your patient. Either a cardiac patient or a patient with diabetic renal disease, they need to be on an ACE inhibitor. A lot of the doctors are very lax, saying, you know what, potassium is 6, intolerant to ACE inhibitor. We know that you're doing a disservice. These are very powerful medicines that can actually improve mortality, improve survival, and slow down progression of diabetic kidney disease. So that's why I want to give you that tip, a good tip. But hyperkalemia is a very common problem. You guys remember that the potassium, most of the potassium is in the intracellular space, and there are some conditions that can actually cause translocational hyperkalemia. The potassium can travel from inside of the cells to the outside, and that's the one we measure, the one outside. And can you give me some examples when that actually can happen? Insulin deficiency, very good. So insulin deficiency, that's why one of the reasons, one of the treatments is you give them a little bit of insulin to facilitate that shift to the intracellular space. What else? You guys remember?
Fractures.
I'm sorry?
If you have a fracture, it can cause like leaking of the...
Fracture, any type of crushing trauma, yeah, can cause like release. So it's either because the potassium is coming from overproduction or from translocation from the intracellular space to the extracellular space. Another example, commonly seen in clinical practice, is metabolic acidosis. So acidosis, there's like shift from, in an attempt to correct the acidosis, like hydrogen ions, they travel, and that travels along with potassium ions, and that causes hyperkalemia. And when I was in training, actually, we had a very interesting, it was a very educational case. I want to share it with you so you guys remember from now on. I had a patient with HIV enteropathy, and he presented with a bicarbonate of 12 and a potassium of 2.8. My attending failed to recognize, I was an intern back then, but my attending failed to recognize that the most important electrolyte abnormality on that patient was not the bicarbonate of 12, was actually the potassium of 2.8. So what the attending recommended was to give the patient a bicarbonate drip. And bicarbonate can further exacerbate hypokalemia. The next thing we knew, after an hour of starting the drip, the patient quoted. He made it. Fortunately, he made it, but it was very educational for me to understand that, like, hypokalemia, like in a DKA setting, or in a metabolic acidosis setting, it's very serious. Because the next thing that you do, you correct the insulin deficiency or you correct the acidosis, more potassium goes into the intracellular space, the patients will die. And this is a life-threatening both ways. If it's very low, patients will die. If it's too high, it will die. So in clinical practice, most of the questions on your boards are going to come from hyperkalemia, and they want you to be aware and familiar with the EKG-induced abnormalities associated with hyperkalemia. Do you guys remember which ones are? So it's either like a flattened P wave, prolonged PR interval, widened QRS, and the tall peak T waves characteristic of hyperkalemia. I have a picture here if you guys want to look at it so you never forget about this. And there's prolonged PR, and then when there's actually a very severe, you can actually start like looking at the bradycardia, and then the next things that the patient are going to be coding, and like a PA arrest. So it's very important to understand that you're going to be dealing with, like real time with your patients when you're an intern. The management, it depends on what the main driver of the potassium is, but generally speaking, in emergency cases, we do a little bit of insulin with dextrose to prevent hypoglycemia. We do, some doctors, they routinely use beta agonists, because beta agonists facilitate the shift to the intracellular space. Some doctors use bicarbonate in the setting of acidosis, because it's also one of the treatments. And some doctors use, especially for severe EKG-induced changes, we use calcium gluconate to stabilize the cardiac membrane. I get a lot of calls like, oh, we need dialysis now. I don't say anything, but I laugh inside, because how am I going to give dialysis now if I don't have a line? So a lot of the times, a lot of the doctors, they fail to understand that nephrology, most of the things that I deal with are not necessarily emergencies, because the patients can be temporized. If I have access, even if the patient has access, by the time the dialysis nurse gets in, like primes the machine, connects the patient, starts doing the treatment, we're talking about like no less than an hour of wait time. A patient with hyperkalemic induced EKG changes doesn't have an hour. So, and Lasix, we also use Lasix to try to facilitate, but if the patient is a dialysis patient that makes no urine, it doesn't make sense to give him Lasix, because you need to understand why you're giving it. The Lasix is just to try to facilitate the potassium dumping. But another thing that's important, when you're an intern and you get a patient with a very high potassium, one of the things that you need to rule out is obstruction. Like the patient either has an enlarged prostate or the patient has a neurogenic bladder. What's the most common cause of neurogenic bladder?
Diabetes.
There you go. What's the treatment for neurogenic bladder?
Well, you want to, if it's,
Let's say that I diagnose you today and you're going to go home. What did I tell you? What do you need to do from now on for the rest of your life?
cath.
Self-cath. It's called CIC, clean intermittent self-catheterization. It's pretty sad, pretty painful to see that, and that's one of the things that I use to scare my patients that are not complying with diabetes treatment, because it sucks. I mean, if you think like your life could be worse, it could be a lot worse than having a neurogenic bladder from diabetes. But in male patients, elderly, always when you see like very high potassium, the first thing that comes to your mind as an intern, you need to react immediately and say, hey, is this patient obstructed? Can you please put a Foley? Can you measure a PVR? What's the normal PVR?
Normal what?
PVR, post-void residual.
Less than 50.
Less than 50.
I'm sorry?
Less than 50.
Clinically relevant, probably more than 200 is clinically relevant.
Okay.
So no one should have any urine if you urinate and you have a competent bladder. But to be able to call it like clinically relevant, anything greater than 200. Most urologists will agree that more than 200, because that in itself is a risk of urinary stasis, and some patients, they can get urosepsis or recurrent UTIs, or it can even impair the creatinine. 6768. I'm so sorry. I'm gonna call back this number. I apologize. 67.
So how would you treat hyperkalemia?
Because it's very cost effective and it's very safe. It's not like decades ago when we first started doing PD that the patients were coming up with a lot of complications. Now it's growing in popularity. Yeah, it's overnight. I mean, if I were a dialysis patient, that's probably what I would do. I want to keep my privacy and my productivity.
Yeah.
So, I mean, it's not an easy life. It's not, the field that I do is not pretty. It's hard, but you give them freedom and you give them, quality. Yeah, quality. Very good. So Dr. Ben was talking about like treatment. For inpatient, we cover the treatment. We always use like these resins that bind potassium and you poop it out. We have the more common that you guys know about is the Kayexalate or Kyonex, or it's also known as sodium polyphosphate. I can't remember, like sodium polystyrene resin. And there are new FDA drug approved for the management of chronic hyperkalemia. I think Dr. Ben-Zur uses one of them here. It's called, I forget what the name is. Rami, what's the brand name for Patiromer, or the medication that you guys use for hyperkalemia? No, the other one, the new one. The Patiromer or the... Yeah, I'm going to tell you in a minute.
What's that?
What's the name of the Patiromer, the one that you use for hyperkalemia? Veltassa, right? Yeah, it's called Veltassa. Have you guys heard about Veltassa? Okay, so you're gonna see commercials and everything because it's gotten like FDA approved in the last 3 years, and it basically the same mechanistic way of working as Kayexalate. It's just supposedly more friendly and more effective. They've done studies. The criticisms to those studies is that they were done, the patients that were in the treatment arm, they were not formally educated on low potassium. So what I do is I explain to my patients, most patients that are educated in a low potassium diet, they're able to be compliant. They don't have that many issues with high potassium. Very good. So let me think about hypokalemia. Okay. Okay, so hypokalemia, the only thing I want to cover you is that they give you a person that's crazy on the boards, and they're actually inducing vomiting or using surreptitious diuretic use. Basically, the most common cause of hypokalemia are vomiting and diarrhea, and urine chloride is less than 20. And if they're using diuretics, the urine chloride is almost always greater than 35. So that's one of the ways to, to think about, to approach the case. If you think, like, they always tell you a person that was working in healthcare that is having this chronic hypokalemia, and then you do a urine chloride and it's greater than 35. There are two genetic conditions that are associated with hypokalemia. They are genetic disorders of the transporters. I don't know if you heard about them. I don't think we need to talk about them in depth in this talk, but one is called Gitelman syndrome and Bartter syndrome. Bartter is much less frequent than Gitelman. And the way I remember is that Gitelman is it's like exactly the same effect that a thiazide diuretic has in the kidney, whereas Bartter is exactly the same effect that a loop diuretic has in the kidney. It's just exactly the same type of metabolic abnormalities. But I don't think they're going to test you on that, but more likely they're going to test you on somebody who's using diuretics surreptitiously or purging surreptitiously. So just check the urine chloride. Let's see, magnesium, phosphorus. These things are not going to be on your boards. It's more like for IM. Acute kidney injury, we talk about the muddy brown, CKD, okay. Say it again?
Low and high calcium.
High calcium, oh yeah. High calcium definitely you're going to be tested on your boards. Which condition is the most commonly seen on your boards with high calcium? Which one?
Primary hypertension.
And what's the clinical clue on primary? So the vignette they're going to show you is more likely they're going to give you a patient with a little bit of kidney stones or early onset osteoporosis, and they may have mildly elevated or high normal calcium. Remember, the hypercalcemia associated with primary hyperparathyroidism is not very high. If you see a calcium of 14, that person has a malignancy until proven otherwise. And another thing that's common is low phosphorus. It's like the triad. The classic triad of primary hyperparathyroidism is low phosphorus, high calcium, and high PTH. So those patients most of the times they need surgical parathyroidectomy, because if they have end organ damage, they're going to be more predisposed to hypercalcemic induced end organ damage. There's also another two entities that are less commonly tested, which is secondary hyperparathyroidism. The physiopathology is completely different. There's no adenoma. It's just like gradual increase in the size of the parathyroid glands from multiple different reasons. In kidney disease primarily, we see this in kidney disease primarily, but you can also see secondary hyperparathyroidism from profound vitamin D deficiency. So one of the drivers is, like, when you become vitamin D deficient, the parathyroid glands, they start getting bigger, because vitamin D inhibits transcription of parathyroid hormone in the parathyroid glands. And the second reason is that in kidney disease, the kidneys are not very effective dumping phosphorus. So when you have phosphorus in your diet, phosphorus is readily available in all the foods that we eat on a day-to-day basis. And that's why it's so hard to control phosphorus in kidney disease patients, because you guys know the biggest sources of phosphorus in the diet?
Like green leafy vegetables?
That's for potassium.
That's just potassium.
Yeah, phosphorus is more like a preservative, like in processed foods. In this country, most people eat processed food, especially people living on a budget. They can't afford to buy to cook. So that's probably the most common. Dark sodas has an enormous amount of sodium, so it's a big no-no for a dialysis patient. Unfortunately, nuts, they have a lot of phosphorus. So yeah, so those are primarily, and anything that's milk, cheese, or any dairy, unfortunately has a lot of phosphorus. So those are not good choices for kidney patients. So those patients have a lot of phosphorus, and then the PTH starts getting bigger. Just to give you an example, it can be the size of a lentil. You guys know that most humans have 4 parathyroid glands behind the thyroid, and when in kidney disease, they can get as big as a bean. From all these changes that I'm describing. And there is another entity that I'm sure you're not going to get tested on. It's called tertiary. And the tertiary is, just imagine the parathyroid gland went nuts. Just basically got bigger and bigger and bigger. And I've had patients with PTH level in the thousands, like 3,000, 4,000, and those patients, they have an increased risk of cardiovascular disease and cardiovascular mortality. So make sure you understand the differences between them. So that's primarily for hypercalcemia. There are other conditions that can cause hypercalcemia. I think it's beyond the scope of the talk, but I'm going to mention some of them. Like, for instance, we have the milk alkali syndrome. Patients that back in the days, we call it milk alkali because back in the days before H2 blockers and PPIs, people were treating their peptic ulcer disease with excess of milk and excess of like antacids. Rarely we see that anymore, but you can still see it in those patients that are very, very fond of vitamins and supplements. Believe it or not, I keep telling my students that the people in the United States have the most expensive pee and urine in the world, because people here, like, they have supplements for everything, and the question is, do you really need these things? Most of the times probably you don't. But other causes of hypercalcemia, we have Paget's disease, but that's more like dystrophic bone formation. These patients can have a little bit of a high calcium. We have patients with calcitonin secreting tumors. We have what's the name of that condition that your facial bones can actually grow? Acromegaly. Acromegaly patients can actually have like excess of human growth hormone, either because you have a tumor in the pituitary or because you're using it for whatever reason. Human growth hormone is very commonly used for weight loss, and use and abuse for weight loss in the US. So I've seen actually patients of getting diabetes induced by excessive human growth hormone use. Other causes, let me think. So we have sarcoidosis, which is probably one of the things you may encounter on your boards. Remember, sarcoidosis can happen anywhere. The typical question is an African American individual with a chest X-ray with like lymphadenopathy. This disease is tricky. We don't know what causes it. There's some beliefs to be some genetic background associated with development of this condition. But the good news is that not everybody needs treatment. Only patients that actually with abnormal PFTs or either like involvement of some end organ, they will require treatment. And the treatment is steroids. It's easy to treat. Let me think what else can cause hypercalcemia. Bless you. Yeah, paraneoplastic syndromes, yeah. So from PTH related peptide excess or secretion. So we see that primarily in squamous cell carcinoma, and like I was describing, or people with multiple like bone mets, and that's the reason why in multiple myeloma patients can actually present with very high calcium, because one of the diagnostic or screening testing for multiple myeloma is to do a bone survey, and you can actually see those lytic lesions. They call it, how do they call those lesions? It's like a medallion. I forget, it has a name. But any type of disease infiltrating the bones can actually cause like hypercalcemia. So the distinction is very clear. Like primary hyperpara, mildly elevated. Malignancy or metastatic disease, highly elevated. These patients can present with multiple manifestations of high calcium. Okay, so hypocalcemia the differential is basically either you're profoundly vitamin D deficient or you have hypoparathyroidism. We don't know what causes hypoparathyroidism, but everybody acutely, when you get very sick, the PTH, it's believed to be ineffective, and it's very common when you admit a patient to a hospital. It's very common to have hypocalcemia on the labs. We don't necessarily treat hypocalcemia, especially for those patients suffering from sequestration of calcium. Do you guys remember which entities can give you calcium sequestration? So there's two entities to remember. One is rhabdomyolysis, like when the patients have profound rhabdomyolysis, there's calcium sequestration, and another one is severe pancreatitis, because these patients can actually develop saponification, which is, like all the enzymes that are chewing on the pancreatic tissue, they activate and they actually consume and they sequestrate calcium. So that's one of the things that you have to be aware of, because you don't treat those patients, because when they start getting better, you're going to induce hypercalcemia. But you do treat those patients if they're having a life-threatening hypocalcemia, or if they have EKG-induced changes. One of the manifestations of hypocalcemia is prolonged QTs. So you look at the QT interval, if it's very prolonged, that's an indication to go ahead and start treating those patients. Okay, let me think what else. We can move on to room. So, paralysis. Okay, so CKD, what can I tell you about CKD? CKD in itself is like an hour talk, but...
So what's stage 3, stage 4?
Okay, that's a good, yeah. So about 15 years ago, National Kidney Foundation came up with a classification, stage 1 to stage 5. 5 is the most severe, and then somebody came up with AB, stage 3, AB, C, stage 4. It's not very practical, you know, to go to. For us, it's more like the main reason why the National Kidney Foundation did that was to raise awareness on non-kidney doctors to understand that a lot of the patients were suffering from a disease that they didn't even think they had, because you have to remember that creatinine is it's a very I'm not going to call it inefficient. It varies. You need to understand the clinical context. I get a lot of consults from very muscular individuals coming in with a creatinine of 1.5, and they're being labeled suffering from a disease that they actually don't have. It's just the way they're muscular. At the same time, I get a lot of physicians failing to recognize that an 80-year-old woman with no muscle mass of a creatinine of 1.4, that lady's probably in renal failure, bad renal failure. So creatinine is not very a good marker of a surrogate marker of renal function. So based on those facts, and unfortunately we don't have anything better. They've tried other markers for renal function. They've tried cystatin. They've tried many other biomarkers, and creatinine is as good as it gets, whatsoever. You know, so far. And so what they did is basically they studied like a large population. They were mostly white males, and I don't know if you heard about the DMRD, the disease-modifying renal diet study. So because of the DMRD, they came up with this GFR classification. So it's useful for everyone. I think even for me it's very useful, because it allows me. It's very easy to educate the patients about their kidney power. Although it's not a percentage, I tell my patients this is your kidney power, and it's very easy to track over time. So it's useful for those patients suffering from progressive renal disease. And it's also useful because in nephrology we have a lot of planning. A lot of my work, my day-to-day work, is to start planning. Number one, educating patients that are suffering from progressive renal disease. And you know, I'm sad to report that since 1992, when ACE inhibitors and ARBs were created, we don't really have anything useful or powerful in my field to change the course of renal disease or diabetic renal disease. Actually, there are very promising studies coming in the next couple of years, but so far everything that they've tried has been rejected for whatever reason. The last medication that was promising was causing fulminant liver failure, and they stopped. So for us, it's actually it's more about like educating the patients about what's entailed. If you have progressive renal disease, what are the strategies to slow down progression, and educating patients about transplant, educating patients about dialysis, or educating patients about no dialysis for those suffering, for those with limited life expectancy, or for those that don't even want to consider anything. You know, no dialysis is also an acceptable choice. So that's my day-to-day job, but I think for you guys it's important to understand when you're presenting a patient to an attending, GFR is only accurate if the patient is on steady conditions, like a steady diet, a steady, you know, is not going through acute kidney injury. For acute kidney injury is not very accurate. We use it all the time, but if you're presenting to an attending, you tell, look, his GFR yesterday was 23, today his GFR is 14. In the setting of acute kidney injury, we forget about this GFR thing, because again, it was derived from those studies that they were observed over time in a very steady state of health and diet. In acute kidney injury, we go by the creatinine. Creatinine was 3 and today is 5, so you know that these patients are actually going into more profound renal failure. We talk about, like in CKD, we talk about complications of renal disease. I want to hear at least three. There's like 7 complications, but at least 3 complications of kidney disease. Yeah, so which ones?
Hyperphosphatemia.
Hyperphosphatemia, hyperkalemia. What else? Metabolic acidosis. Anemia. From what reason?
The lack of EPO.
EPO. Very good. What else? And the secondary hyperparathyroidism. So those are the things that I see every time I see someone for follow-up in clinic. I look at the PTH, I look at the calcium, I look at the phosphorus, I look at the potassium, you know, and that's basically, and blood pressure goals and diabetes goals and nutritional goals, because one of the components of the uremic syndrome is that the patients, they start eating less. And the uremic syndrome is something that happens very subtle. It's not something like I'm fine today and tomorrow I'm uremic. It doesn't happen that way. Most patients, in fact, one of the things I like about my job is that I have to convince them that they're sick, because the changes happen in such a slow fashion that they kind of forget what it is to feel right. And they do feel the difference when you start giving them dialysis. They start, like, appetite is improving, stamina, energy, sleep, concentration, everything improves. Okay, so, okay, I'm going to talk briefly before we move into room about nephrotic and nephritic syndrome and GNs. Okay, so nephrotic syndrome. So important things to know is that the ultimate diagnosis is made with a kidney biopsy. I was just telling you guys that we don't do biopsies on everyone because you have to have normal blood pressure and you have to have a plan. I don't biopsy the patient just for the sake of knowing what the diagnosis is. In other words, if I have a patient who's a heroin user, is non-compliant, he shows up every 6 months to the clinic, why would I bother doing a biopsy? Number one, I can't give him immunosuppressant medication. If I have a patient with an active osteomyelitis, I can't give him anything. I can't give him even prednisone because he's going to die from a rumen infection. So the same principle applies. When I make a decision about diagnosing a patient, I need to make sure that they're not only medically optimized by not being on anticoagulation, by being normotensive, but also what am I going to do with that information. But the ultimate diagnosis for nephrotic syndrome basically they created this name to describe those patients suffering from massive protein loss in the urine, that it goes along with hyperlipidemia, it goes along with vitamin D deficient, they become very profoundly vitamin D deficient, it goes along with an increased risk of DVTs, because when you have severe nephrotic syndrome, you're losing the natural anticoagulants, which are protein C and protein S, and you're predisposed to have infection with clots, and you're also predisposed to have infection because you're losing your immunoglobulins. So part of the standard of care of managing this patient is to vaccinate them against primarily encapsulated organisms like pneumococcal infections or Neisseria meningitis. They're at risk of developing these infections. But ultimately, I can presume, most of the time my presumption is correct, but the only definitive diagnosis can be done with a renal biopsy. And I'm going to ask you guys, what diseases do you remember that are associated with nephrotic syndrome? Which one is the most common cause? Diabetes is by far the #1 cause of kidney failure in the world, accounting for 50% of the dialysis patients. And the only difference about diabetic nephrotic syndrome is that they don't get clots and they don't get the increased risk for infection. More so for the other causes. But I wanna point that out. What else?
Other nephrotic syndrome?
Which ones?
Minimal change disease.
Minimal change disease, very heavily tested on the boards, especially in kids. You don't necessarily need a biopsy in a child presenting with like nephrotic range proteinuria. You give them a little bit of prednisone and they get better. Sometimes the triggering can be either they took an NSAID or they got stung by a bee. You know, some patients are susceptible to develop nephrotic syndrome from a bee venom. And adults is a whole different story. If you get an adult with minimal change disease, you have to think about lymphoma, non-Hodgkin's lymphoma, until proven otherwise. So that's one of the questions that they may ask at disease association. So minimal change disease in an adult, think about non-Hodgkin's lymphoma. What other examples do you guys remember?
IgA nephropathy.
IgA nephropathy is mostly nephritic. We'll talk about it in a minute.
Amyloidosis.
Amyloidosis, yeah, amyloidosis is actually, you don't biopsy those patients because you can they can bleed to death. They have a lot of increased risk of bleeding. It's easier to make a diagnosis with oral mucosa or a fat pad biopsy, just to look at the red Congo stain. But amyloidosis, you guys know, can be primary or secondary amyloidosis. I've seen a lot of secondary amyloidosis from patients with chronic osteo or some sort of chronic inflammation, like patients with rheumatoid arthritis, like burnt out rheumatoid arthritis, can present with renal amyloidosis. One of the things is that the kidneys can be enlarged. What's the size of a human kidney, you guys remember?
The size of your fist?
Your kidneys are probably higher, bigger than any other kidney here in this room. The taller you are, the more, the bigger the kidney. But it's about 10 to 12 centimeters. So renal amyloidosis can present, same as lymphoma of the kidney, can present with enlarged kidneys. And another differential of enlarged kidneys, polycystic kidneys, but you're going to be able to see the cysts surrounding the kidneys. Which other nephrotic syndromes, diseases associated? Which one? Membranous. So membranous can also be idiopathic. It's no longer idiopathic because we already know that it's actually a pathogenic antibody deposition. It's called the anti-PLA2 antibody. It causes deposition and inflammation, and people start like spilling a lot of protein. That's what we call idiopathic, because we didn't know the cause for a long time. Now we know the cause, and we actually have an assay that you can send for those patients that are not candidates for biopsy. You can send that. And it's useful because the treatment, if it's primary or idiopathic membranous, the treatment is very different than if it's secondary. If it's primary, you treat them with, you either decide on observation, depending on how critical the proteinuria and the renal function is, or you can decide on treating them with cytotoxic agents, steroids, or calcineurin inhibitors. So, but that's a whole separate thing that doesn't pertain to you guys. But when it's secondary, there are diseases that are associated with secondary. The most heavily tested on the boards is hepatitis B. So when you see hepatitis B related renal disease, membranous, secondary membranous. But you can also develop membranous from syphilis. That's one of the malaria. You can even get it from a drug reaction like to Plavix or diclopidine, which is another antiplatelet agent. You can develop even to captopril, which is the old-fashioned ACE inhibitor, can cause secondary membranous. So the differential for secondary membranous is long. But the key thing to understand, to remember, is that if it's primary, the pathologist, the renal pathologist, is going to tell you this looks like primary versus secondary. They have very different findings. Okay, what else? Which other disease associated with FSGS? So FSGS is moving up on the popularity, unfortunately, because we have obesity epidemics, and obesity is one of the problems with the kidneys. You can develop FSGS. FSGS can be seen on your boards in instances like HIV nephropathy. You know, these patients develop like a type of FSGS called collapsing FSGS, which is pretty severe. Patients can actually, heroin users can actually have FSGS, secondary FSGS. You can see that in prematurity. When you're very preemie, you ask your patient, hey, were you a preemie? That's a risk factor for developing FSGS. And then having a large body size. And that's why there's a lot of like sportsmen in the United States with this condition. And there's a theory on hyperfiltration. In other words, if you're a preemie, your kidney is working very hard to compensate the needs. If you're like a muscular big athlete, your kidney is working pretty hard. If you're an obese person, your kidney is working pretty hard. So it's going up in popularity, and I think it's now the second most common cause of nephrotic syndrome. I mean, besides diabetes and membranous. Okay. All right. So nephritic. So nephritic patients, they tend to have protein but less protein in the urine, and they tend to have higher blood pressure. They tend to have red blood cells in the urine. Remember, we talk about acanthocytes or dysmorphic RBCs. So those patients can actually present like that. Okay, glomerulonephritis. So which nephritic syndromes do you guys remember? Post-streptococcal. Is it really bad to have that, or you think it resolves, or?
Is it like a third gets better, a third stays the same, a third gets...
That's for membranous.
Dang it.
That's for membranous. But the good news is that most patients with post-streptococcal, they recover. Yeah. So we have IgA nephropathy, which is the most common GN in the world. Most cases of IgA nephropathy, they go unrecognized. Most cases they go indolent, but IgA can behave from a very indolent, very aggressive, found incidentally because when people are trying to buy life insurance or something, they saw blood in the urine, to a very aggressive type of disease, like a crescentic IgA nephropathy. Those patients you need to treat very aggressively. I have a 19-year-old Filipino lady with that condition. So it's common, IgA nephropathy is common in Asians, like Southeast Asians, and Hispanics. That's actually the two more common groups that you can see that. The treatment depends on, like I said, depending on how severe or how compromised, and you can only treat it when it's discovered early. If you get a patient, like this week I got a lady with a GFR of 24, the horse has already left the barn. I mean, there's nothing I can do. I just need to make sure I prepare this lady for a transplant. Okay, so IgA, what other nephritic conditions you guys remember?
Progressive.
Which one?
Progressive mental glomerulonephritis.
FSGS? FSGS falls into the...
No, the one with good pastures and...
Oh, you're talking about anti-GBM nephritis? Yeah, so that's actually, it could be nephritic, but it can also present as an RPGN. Have you guys heard about RPGN? Rapidly progressive glomerulonephritis? Yeah, so RPGN, it's one of the few emergencies in this field, and it's actually the biggest fear of a nephrologist is missing out on an RPGN. It's like Dr. Ben-Zur missing out on an LAD lesion, because the next thing I see that patient in 3 months, the kidneys are probably going to be gone. So it's that critical. So there are a few syndromes that can call an RPGN. One is good pastures. We call it good pastures when it involves the lungs and the kidneys. When it involves the kidneys, we call it anti-GBM nephritis. But you can also see that in ANCA-associated vasculitis. You guys remember ANCA? So ANCA is actually is more common than what you think, and the disease ANCA-associated vasculitis is a small vessel vasculitis that can present with or without renal involvement. In primary care or family medicine, you're going to see, if you see adults with severe sinus disease or severe otitis, throw an ANCA. You'll be surprised, because adults should not get recurrent otitis. You know, that's childhood disease. It's not, unless you're a smoker, unless you have some structural abnormalities. But if you get a patient with recurrent otitis, recurrent sinusitis, just throw an ANCA on it. I recently diagnosed a patient in the urgent care who's been suffering for 10 years with this, and I told him, like, I think you have ANCA, and I sent him, and sure enough, he has ANCA. He was so appreciative because they were treating him for infections that he never had, ever. It was just vasculitis. So in the kidneys, actually, when you have severe ANCA, ANCA is divided in 3 conditions. I'm not going to go into details, but I'm going to tell you the names. Formerly known as Wegener's. We call it like granulomatosis with polyangiitis. Then we have a second one called microscopic polyangiitis, MPA. And we have another one called Church-Strauss, and I think they removed that name as well. It's called eosinophilic granulomatosis with polyangiitis or something like that. It's a long name. So those are the three small vessel vasculitis associated with ANCA, and we call it ANCA because you test positive for some anti-nuclear antibodies, but once they do the screening test, they need to go and look at the immunofluorescent microscopy, and they need to look at the pattern. So sometimes the pattern is you see the antibody deposition around the centromere. We call that C-ANCA. And when you see that deposition around the nucleus, the perinuclear pattern, we call that P-ANCA. So we know that C-ANCA patients are more likely to have Wegener's, P-ANCA are more likely to have like the MPA, but you can see a lot of overlap. The key thing for you guys for your level of training is that this goes into the pulmonary renal syndromes. You can have lung and kidney moment. Rami, ask your favorite water, please. Thank you. So that's basically the vasculitis, and there is from the RPGN. Now that you touch on this, the RPGNs, we can see lupus. Lupus is pretty nasty with the kidneys. Lupus can have 6 different patterns described by the World Health Organization. I'm not going to get into details, but one of the patterns is actually that you can develop an RPGN, and if you missed out, that patient is going to be on dialysis. Before we were able to successfully treat renal disease, the mortality of lupus was pretty high. It was a very lethal disease. Now that we're able to diagnose and treat it, the mortality of lupus is close to the average population, fortunately. This is a bad disease. Thank you, Rami.
Sure. Good to get free water.
Thanks. So the other nephritic syndromes, we have you guys heard about it's in children primarily, that's why I don't remember the name, because I never see it in adults. Alport is a X-linked disease. The mother is the carrier, and I think the son is the one that develops it. You develop like hearing problems, but it's a form of IgA nephropathy. Some researchers believe that this is the same as IgA nephropathy. No, I'm talking about the one that gives you a salmon rash. It's in kids. HSP, Hennes-Scholem purpura. HSP. I never see it because I don't do peds. But yeah, but in your boards you may get tested on HSP. It's like a sister disease for IgA nephropathy, but it's more commonly seen in kids. They give you that yeah. And then another disease association I want to remind you guys is, I already told you the hepatitis B with secondary membranous. I'm going to tell you hepatitis C with membranoproliferative glomerulonephritis, and hepatitis B with another entity called polyarteritis nodosum. So they may give you a picture of a renal angiogram and you see a bunch of little aneurysms in the kidney. So that's hepatitis B until proven otherwise. Remember that. And then I told you about the minimal change disease in Hodgkin's, right? So those are like, oh, and membranous can also be associated with solid organ malignancies. Solid organ malignancies, that's another association, common association. Put the phone. I'm so sorry, I'm gonna have to return a call really quick. Call KP dialysis unit.
Calling KP dialysis unit.
Hi, Dr. Lopez.
Hi, Maria. How are you?
Good, good. So someone is going to be admitted.
Mm-hmm. Yes.
Who's Claudia?
Yeah. So, do you know her prescription?
She is 10 hours, 2,500, and 2%. I know by heart, by the way.
Okay. Does she have a last? Does she have a last fill?
Yeah, she has a last fill.
Okay. So it will be a total of like 5 exchanges, 2.5 liters each, and a last fill of 2.5.
You know what? No, usually it's 2.
The last one is 2 liters.
It's 2.
Okay. Okay. And is she hypotensive or she's hypertensive?
She's less blood pressure. She's throwing up a lot.
Yeah. Let's use the yellows.
Blood pressure 108 over 66.
Yeah. If you can please put her on the 1.5%.
Oh, so you just want a 1.5?
Yeah.
And then, did you see her result?
Not yet. Dr. Kim was going to call me with the result.
Right now. So clear RBCs is 4, nucleate cell count is 3, DMS 10, PMS blood fluid, lymphocytes 70, monocytes 20.
Mm-hmm. So she doesn't have peritonitis.
Yeah, no, she doesn't have it. I already knew when I draw because it's very, very clear.
She probably has some gastroparesis or ileus for some reason. Yeah.
Do you want her in dialysis?
Yeah. If you can please put her on the cycler, but just use the 1.5% dextrose solution.
1.5 and 2,500.
And 2,500. Yeah, the same home prescription, but let's use yellows for today.
Yeah, and last fill.
And the last fill 2,000. Mm-hmm.
Yeah, that's what usually she gets. So 1.5. Okay.
Perfect.
She's still on the ER, so I don't know if what I'm going to do is wait for.
Yeah, hopefully she'll get a bed soon.
Yeah, we're going to try to see if we can get her back very quick.
Perfect.
Okay.
Thank you so much. Have a great evening.
Okay,
Thank you. I'm sorry. I was talking about a PD prescription. You guys know how PD works? You've never seen PD, right? Okay. Have you seen hemo patients? Hemodialysis? A little bit. So PD is I put sugar in the tummy and I get water and toxins. That's why I was just talking about her. Like, there's 3 solutions. There is a yellow bag, and there is a green bag, and there is a red bag. The yellow bag is the lowest dextrose concentration, is 1.5%. The green bag is 2.5%, and the red one is 4.5%. So it's pretty powerful. So the more dextrose, the more gradient I create. So the principle of PD is I work with a gradient. I put a solution containing dextrose, and that causes migration of solid and water by concentration. So concentration gradient. So if I have no BUN in the solution, the BUN is going to travel. And that's how it works. It's pretty nice and neat. The problem is that it's not forever. You know, eventually the peritoneal cavity starts degrading. It's not like people on hemodialysis. I can use a membrane and I throw it away. PD patients, I cannot throw away the peritoneum, so I have to try to preserve it. But patients get probably a good 10 years of treatment. In the state of California, the wait time is about 8 to 11 years for patients that are getting a kidney. It's very sad. In Indiana and in the other Midwest, it's actually pretty quick. People can get it within a year. Here it's pretty prolonged. Have you guys gone to a restaurant here on Friday at 6 p.m.? You have to wait like for an hour to be seated. Same thing happens when you're aspiring to get an organ in LA. Yeah. Okay, so I was telling you guys about the disease associations with glomerulonephritis, because that's another area that's heavily tested on your boards. Okay, let me think. Renal tubular acidosis. All right, stones. Okay, so stones, I want to say 2 things. Most of the stones, you guys know, is calcium oxalate, but we also have like a lot of different compositions. The things that they always try to trick the students is that don't ever select a low calcium diet. Don't ever select a low calcium diet. And the reason is that although the most common stone is calcium oxalate, when you have more calcium in your diet, you actually bind oxalate. And that's why you never select low calcium in the diet. When you select low calcium in the diet, you're favoring absorption of oxalate and deposition of oxalate in the kidneys. Have you guys heard about oxalate nephropathy? Have you guys heard about that? Have you seen a lot of bariatric patients in your school, medical school? So there is a bariatric surgery like the Roux-en-Y. Have you heard about the Roux-en-Y? Okay, so those patients develop, unfortunately, a small percentage of those patients, like 5% of the patients, can develop oxalate deposition in the kidneys, and unfortunately they develop ATN, and ultimately they go into dialysis. I have 2 patients on dialysis after bariatric surgery. That's called oxalate nephropathy. And what happens is that they have increased absorption because they have a shorter gut, so there is not enough transit time for the calcium to bind the oxalate, and they end up developing increased absorption. I think it's locked. Sir, I think it's locked.
It's happened before.
Yeah? So how do we exit?
Oh, we have to go out that way.
That door?
But it's closed, if it's a patient.
Oh, yeah, no. He said, how do we exit?
Oh, us. Okay.
Us. Yeah. We're here until tomorrow?
Yeah, we here
Very good. So don't be tricked. Never select low calcium diets. And then calcium restriction does not prevent stones and may actually increase stone formation and contribute to bone demineralization. Okay? And absence of red blood cells in the urine does not rule out nephrolithiasis. That's very true. Actually, you can still have the stone, so don't let them trick you.
So what do we do to prevent, I guess, stone?
For stone prevention? Yeah, so it depends on that's a great question. So it depends on the composition of the stone. So as a kidney doctor, I always want to have a stone analysis. That's in the perfect world. In the real world, I rarely get the stone. You can tell your patients if they actually have stones and they're passing, you need to give them like a strain, so they can try to collect it to send it for analysis. But you can play by the statistics. So like I said, most of the patients have calcium oxalate. If they have recurrent calcium oxalate formation, it warrants a metabolic evaluation. The most common cause of calcium, I think they're all gone. I cannot open the door, sir. It's locked. The door is locked.
Steven. Oh, Steven, what are you doing?
No.
Who is Steven?
He's another student.
Oh, can you go around?
Go around, I'll let you in.
Why isn't he here?
He's visiting his family now. He just got back, I guess.
He's from your med school?
No.
Okay. Let's wait for Steven.
He's from Alabama.
He's from Alabama?
You're gonna hear that real fast.
Where are you guys staying? Are you guys staying here or in different places?
I'm staying in West Hollywood.
Have you guys liked so far, LA?
Yeah.
It's crazy, huh? Well, the weather is really nice. That's my. Now it's pretty hot because the valley is pretty hot, but most of the year the weather is beautiful. Like summer is my least favorite season because it's too hot. But let's say like October, November, you still have plenty of daylight and the weather is beautiful. It's just gorgeous. Yeah.
Did you apply for residency as an international?
Yeah, of course.
And so you did residency with Kaiser or you?
No, I did it with UCLA.
Oh.
And then I was faculty there. I stayed, I was teaching, and they offered me a job at Kaiser and I bailed. I don't regret it. It was great. It was the best decision I've ever made. Yeah.
You go to the hospital in Woodland Hills?
No, I go to Panorama City.
Okay, I'm applying for the program in Woodland Hills.
Oh, you are?
Yeah.
Good for you.
Yeah.
For family?
For family.
They have only 2 spots or something like that? Or
So yeah, something like that.
very small?
Yeah. It's very
Good. I hope you get it.
Oh, thank you.
It's great.
I hope so.
It's great. It's great. Where else are you applying?
I'm applying to Kaiser and Napa as well, and then some of the UC schools, and then back up in Oregon. That's where I'm from at Oregon Health and Science University there too.
Nice.
Several places.
You don't mind California, right? Or are you coming here? Would you? You don't mind leaving Oregon?
Yeah.
You want to come here?
Come here. Oh,
Nice.
no, yeah.
Yeah, that's nice. Nice to meet you, Steven.
Likewise.
I'm Eduardo Lopez. How are you?
Steven, good to meet you.
Yeah, good to meet you. I'm sorry we're in the middle of the lecture, but we're trying to do a cover. We're covering nephrology and we're covering rheumatology. Let's see how far we can get. Good for you. It's a great hospital, great program. Yeah, the Kaiser system here is. I don't know how much you know about Kaiser, but Kaiser is a non-profit, but it's probably, if we were profit, there would be like Fortune 500 number 30 or something like that. They have 1 out of 5 Californians have Kaiser, just to tell you that we have 10 million members. And it's divided by regions. We have like a North Atlantic region, we have Hawaii, Northern California has their own medical group, Southern California, we have our own group. And from the group that I belong to, there is like, I believe like there's 8,000 physicians or something like that. We have 13 medical centers, and Woodland Hills is separate from my medical center.
Oh.
In other words, we meet every quarter or something like that, but the budget, the leadership, and everything is separate per medical center. But it's a great place.
Okay.
Very good. So, okay, very good. So we're talking about stones. Oh, so you were asking me. So, if you're forming calcium oxalate on your boards, you always need a PTH because patients may have primary hyperparathyroidism, right? So also some patients have a predisposition to have increased calcium excretion. So when I don't have, like I told you, the perfect world is to have the stone analysis, but I don't have the stone analysis, I can make conclusions based on the composition of the urine. So what I do is I order a stone analysis, a 24-hour urine metabolic analysis, and the 24-hour urine metabolic analysis includes calcium, oxalate, phosphate, uric acid, citrate, and sodium. And based on those 6 pieces of information, I can conclude what is the likelihood, what is this patient likely to be forming. Just to give you an idea, what is the recommended sodium intake in a 24-hour period? 2,000 milligrams, right? So the way they tell you is you have to actually make the math, because whatever number they give you, you multiply that by 23, which is the molecular weight of sodium, and that tells you the amount of 24-hour sodium that the person is ingesting. I had a funny thing to share. I had a lady with multiple calcium oxalate stones, and I kept telling her, are you following a low sodium diet? And she said like, yes, I eat low sodium, I eat low sodium. So I did a 24-hour urine sodium, and to my surprise, or actually to her surprise, she was like somewhere like 7,000 or 8,000 milligrams of sodium. So she was exceeding the recommendation like by 4 times, and she thought she was doing a good job. So remember, most people in the US, we have excessive amounts of sodium. They've done epidemiologic studies, and the average consumption of the American diet is about 4,300 milligrams of sodium. And for anybody with kidney disease, heart disease, or stone formation, the recommended sodium intake is less than 2,000. And the reason is because sodium gets absorbed simultaneously with calcium in the loop of Henle. So that's why we know for a fact that one of the major drivers of recurrent stone formation is high salt diets. So basically, if I have a patient